Welcome back to the Pelvic Health Summit. I'm your host, Hannah Matlock, and today we are here with Dr. Tayyaba Ahmed, a doctor of physical medicine and rehabilitation at Pelvic Rehabilitation Medicine here in New York City. Thank you for being here.
Thank you for having me.
I'm excited. So can you first tell us, what is an osteopathic physician?
So I was just telling a patient this today. When you apply for medical school, you can apply to osteopathic medical schools or allopathic medical schools. The only major difference between osteopathic and allopathic, the MD versus the DO, is that we as osteopaths have to take a course called osteopathic manipulation. It's not chiropractic care, but it is kind of similar in terms of readjusting, evaluating the body for any misalignments or unalignment in the hips, the joints, the shoulders. And so you can do osteopathic manipulative treatments anywhere in the body. The whole concept is the body is whole, it's one, so it's all connected. So, your toe could then affect your knee, which then could affect your hip, which then could affect your other hip, and that kind of concept that your body is one unit.
Right. So as a pelvic pain specialist who treats both men and women, can you explain some of the symptoms that you see patients come into your office with?
Sure. I see men and women, so I would say about 40% of our practice is males and 60% are females, solely because we see a lot of endometriosis, and endometriosis is 1 in 10 women, so just by that we see more women. But we see men and women. So the men usually present with penile pain, testicular pain, pain in their perineum, pain after ejaculation, soreness in the perineal area. They might have rectal itching, rectal burning. They may have a sensation of urine on the tip of their penis. They may have pain in the shaft of the penis. They may have groin pain, pain over their pubic bone, and then present with urinary urgency, urinary frequency, urinary burning. They might have chronic constipation. They might have IBS type symptoms, which are presenting with alternating diarrhea and constipation. The females similarly have the same GI urinary symptoms, but they may also have pain with menstruation. They might have pain that is not just with their menstrual cycle, and it might be longer, a week before, including their menstrual cycle, and then a week after. Sometimes it's all month long and doesn't go away. And so a lot of these symptoms overlap, and a lot of people can't figure out that what's the root. Is it a gynecologic issue? Is it a GI issue, or is it a urologic issue? And so that's what makes us a little bit different as physiatrists, is that we can kind of step back and look at it from a whole. And we spend about an hour and a half with each patient trying to figure out all of those symptoms and kind of figure out a diagnosis based on that. And abdominal bloating, I forgot to mention.
Can you kind of walk us through, when a patient comes into your office, what this first visit looks like?
So I just came from 3 new patient visits. Every patient comes in, I spend about an hour and a half, like I said. The first 15, 20, 30 minutes will be a history taking, figuring out from their first period or from their first onset of symptoms, any past surgeries when they were a child, any hernia surgeries, because a lot of kids will have, not a lot of adults will have the surgeries as children, and those could potentially be affecting their symptoms. Then we go through what's going on currently, who they've seen, what providers they've tried, what medications they've tried, what imaging they've had done, what imaging they have not had done, so we can kind of get a look at that. Then I go through some history questions in terms of any unwanted sexual contact, any TMJ or migraine history, any tailbone falls where they've fallen skiing or fallen on ice, that could be impacting their musculoskeletal system. Any history of spinning, biking, are they big skiers and fall on their tailbone a ton, or do they have like an exercise history that's like 225 miles a week biking? So we go through a really detailed history, going through everything. Then I go into an exam. I examine their spine, I examine their hips, I examine their pelvic floor internally and externally. And after that, I will go through an education portion where I sit with them and I explain, like I have props. So I have a model, I have a poster, I have some photos, and I kind of go through what the muscles are of the pelvic floor. Then I go through the nerves, explaining the blood flow and how important circulation is in the pelvis. And then we talk about which muscles do what and why they're important. And then we make a treatment plan. So based on their symptoms, what they haven't done, what they haven't tried, what they want to try, what they're willing to try. It really is very dependent on the person. Sometimes it's just a lot of investigation in the beginning. Sometimes it's, if they've never done physical therapy, it's start off with some physical therapy, let's do some investigation, come back in 4 weeks. Sometimes it's, well, they've done physical therapy and they're coming from a physical therapist, so it's let's add in some stuff and then follow up. And then sometimes it's procedures. And if that's the case, then we kind of have like a protocol that we'll do.
And so in addition to physical therapy, what are some other treatments that you use in your practice? I know that you do a lot of injections and you also work with different medications that help calm the nervous system. So can you talk a little bit about those two treatment options as well?
Okay. So a lot of patients, when they've been in pain for longer than 6 months, it affects their central nervous system,
right,
as you touched on. So we want to treat things that work on their central nervous system, including yoga, meditation, acupuncture, and nerve medications. So we try, if patients are very hesitant towards taking oral nerve medications, that's fine. We give patients a chance to work on trying to change or perceive their pain with meditation. And we're big advocates of that. We require that all of our patients do a little bit of yoga every day, 10 minutes, nothing crazy, nobody's becoming yogis. We're all just trying to do a little bit just to get the blood flowing in the pelvis. And then in terms of nerve medications, I go through the 4 categories of them and try to see what they've tried, what they haven't tried, and what could be a benefit to them. If there is any psychological impact going on, they may need something that can work on the mood a little bit. And then I'll work with them. If they already have a psychiatrist that they're seeing, I may reach out to them to try to figure out what would work better for them. Sometimes medical marijuana is an option, as well as CBD, depending on the person and depending on their chemical sensitivities and how much they can tolerate. And then there's the peripheral nervous system. So we want to treat them with physical therapy and injections. And then there's also Valium suppositories and different combinations. We've been playing around with a lot of combinations of suppositories, which have been working well for different patients. Sprays and creams and things that in the past were not really used, and a lot of what we do, we're learning with our patients because this is such an emerging field that we have no shame in our game. We're trying to learn just with you guys, like just with the patients too, and use basically we want everyone to get better too. We're not giving up on our patients. So we keep trying to find new things, and every time something gets approved in the news, we're like, maybe that would work. Let's try that.
Right. And going back to the injections, how do the injections work and where do you do the injections? I think that's something that many people listening might be wondering.
Okay. As a physiatrist, we are trained to do them outside. So we don't go intravaginally or intrarectally, which is a huge thing. A lot of people freak out when they hear like injections. We're not going inside the vagina or inside the rectum. We're doing them with ultrasound guidance. So we use the bony landmarks to find the spots that we need to go in. We're going into the pelvic floor, so it may be a long needle per se, but thin. We use a very thin needle because we want to get inside there, and we want to create space into the pelvic floor where the pelvic floor is tight and it's contracted and it's spastic. And when they're tight, contracted, and spastic, just like muscles in your neck, you want to loosen them up. And so a trigger point, if you think of it like a ball and you stick a needle in there, the trigger point will relax. Similarly, we're doing that in the pelvic floor. At the same time, we're also doing a nerve block, which is nice because we can block the pain of the nerves that are in your pelvic floor, which are the pudendal nerve and the posterior femoral cutaneous nerve. So often we see that most of our patients get some sort of immediate relief from the trigger point injection, but they also get long-lasting relief from their pudendal blocks. So the reason we do them once a week for 6 weeks is so we can create and change the environment of the pelvis. And essentially by doing this, in combination with the physical therapy, in combination with possible suppositories or possible cognitive behavioral therapy, and we always think of what we do as a whole package. It's not any one thing that makes someone better, it's the whole plan.
And what are in the actual injections?
So typically, for someone who is not chemical sensitive, who does not have diabetes, we would start off with dexamethasone, which is a very light steroid. The reason we do that is because it's an anti-inflammatory. We want to decrease inflammation. We also put lidocaine in that same injection so we can give them that numbing relief, and then we want to create that space. So just putting something in there where there's these tight muscles will create space. I often tell my patients, if you think of a bowl of spaghetti where there's just lots of spaghetti and there's no spaghetti sauce, you put the liquid in there, now everything can kind of flow. And so then after we do the steroid in the first 2 weeks, we switch over to something called Trameal. Trameal is arnica. It's a plant-based anti-inflammatory medication.
So after you have the patient come in for 6 weeks, do they see lasting benefits beyond these 6 weeks, or is it something that they have to repeat?
It really depends on the person and the cause of the pain. So for women with endometriosis, that's a lifelong condition. That's a little bit harder to treat, and sometimes patients will need that as maintenance therapy, just like physical therapy is their maintenance therapy, possibly for years.
Right.
Similar to Valium suppositories as well. For a patient who has 2 weeks of, I think I even said that to you. I had a patient who only had pain for 2 weeks, and it's relative. When they have a shorter duration of pain, it's much easier to treat. And most of those patients usually never come back for more injections, because it's more of a musculoskeletal type issue that actually just gets better, and they might be okay with doing PT maybe once a month or once every other month, and then they'd get discharged. If it's something that's more of like a stress thing where they're very anxious personalities and they're constantly clenching their pelvic floors, they may need to come back for another series at some point. But if they can get their stress under control with a therapist, then sometimes they never come back. So it really depends on the person.
And then a diagnosis that I want you to talk about a little bit in specific is PCAD, which stands for persistent genital arousal disorder. And as you see often, it is a condition that overlaps pretty closely in both men and women with bladder pain, vulvar pain, rectal pain, and this condition isn't talked about very often, I assume because a lot of shame comes with it, and no one really wants to talk about that they're having these problems. So as a physician, what is the overlap that you see, and what is this pain caused from?
So that's kind of a tough question. There's a lot of speculation that it's related to the lumbar spine, possibly due to some cysts in the spine at the S2 to S4 nerve roots. We're not 100% sure, mostly because there's not a lot of people who will do a procedure to do anything in the spine. It's very dangerous. It's a risky area. PCAD is very difficult to treat depending on the chronicity. So I've seen patients who've had it for 20 years. I've seen patients who've had it for 2 weeks before they come. So it really, really, really changes how their prognosis will be depending on when they come. That doesn't mean that, the patient who had it for 20 years, and when we treated her, the symptoms went 50%. Well, that's still better than having it 100% of the time. Whereas the patient who had it for 2 weeks, it went away within 6 weeks and then it was never brought up again. Because of the shame associated with it, a lot of people don't want to discuss it because there's a lot of people who will think that that's like a funny disease to have. Oh, that sounds really enjoyable. Like I would want that. But it actually can be very like detrimental. A lot of people have had to quit their jobs, quit their work because of, just having that constant sensation that's not able to go away. It's something that patients don't even tell their family members. They don't even tell their spouses about this condition because they feel so ashamed about it. And often, sometimes they grow up thinking like, in certain backgrounds and cultures where, they shouldn't masturbate or they shouldn't. So patients have actually asked me like, is it because I didn't, or is it because I did? And it has nothing to do with actually enjoying it. So, PCAD is not about feeling aroused. Like you don't want to feel that. You can't control it.
But this is something that you do treat in your practice and that you've seen pretty successfully be resolved from the different treatments that you use.
Yeah, 100%. We've definitely worked with a lot of PCAD patients.
So going back a little bit to when you were talking about the pelvic floor physical therapist that you refer out to, what other physicians are you often sending patients to, or where are patients coming from, and where do you kind of fall into this role of the pelvic health care team?
I'd like to think we're the quarterbacks because we try to coordinate care. Our pelvic physical therapist friends send us a lot of patients. I always tell patients when they ask me, how come you guys weren't around years ago? Because this is such an emerging field. The pelvic physical therapists have been doing it way before the doctors. And so I feel like they guide us and we guide them and we work together. But we do work with GI doctors, GYNs, endometriosis specialists. We also work very closely with a lot of sex therapists, marriage counselors, and somatic therapists as well. A lot of our patients do need that cognitive behavioral therapy and even EMDR and other different types of techniques to treat some conditions like OCD.
And so the work that you do in your practice, in addition to pelvic floor physical therapy and cognitive behavioral therapy, talk therapy, relationship, sex therapy, all of these practices take time to see results. And I know that this is something that you're pretty good at explaining to patients who come to your office. How can they wrap their head around the fact that healing these chronic pelvic pain conditions is not something that's going to happen overnight, and that it really does take patience and time and persistence and work as a patient to heal yourself and to work with these practitioners. It's not just a quick fix.
I get every single day asked by a patient, like, okay, what is the percentage I'm going to get better?
Right.
And everyone is very in doubt because by the time they find us, they're like, should we believe you? Like, they doubt a little bit but I tell them, once you've stepped in our door, you're in the right spot. We understand what you're doing and you can only get better. You can't get worse. Trust me, you can only get better. And so this isn't a race. This is more about peeling the layers and figuring out what's the cause. And even just within 2 weeks, you'll notice a slight improvement. But the most important thing is to be able to step back and say, okay, when I walked in her door, I was at an 8 out of 10. And then when they come back for their injections and their 6-week follow-up after that, they'll be like, I'm at a 2. And they'll be like, but I'm not better yet. And I always have to remind them, like, do you remember when you walked in and I couldn't touch your stomach and I couldn't do anything because you were in so much pain? And they're like, oh my God, you're so right. A lot of people are in a rush. Everyone's in a rush to get everything done. And so it's more about stepping back and seeing, what are my gains? Like, oh, am I getting up every night, 3 times tonight to pee? Am I getting up? Am I like super constipated anymore? Oh, my bowel movements are actually better. The little gains. It's the little things. And so having a log is nice, so like a diary. You can put it in your phone. There's so many apps now that you can log up all your symptoms, and you can say, like, on a day, my yesterday was like a 5. Was it, and label it, like, what was my pain? Was it my rectal pain? Was it my perineal pain? Was it my vulva burning? And write down what you think it was yesterday. And then every day do it. And then look back in a month and say, okay, well, those small little gains will make you feel more confident that you're going in the right direction.
And I think that that's so important for people suffering to hear, because when you don't feel well, you forget the times where you did feel well. Mm-hmm. And you have to remember that those times did exist, and you will be able to get back to those periods.
Exactly.
You have to kind of just be able to be patient.
Exactly.
So a large challenge in navigating the world of pelvic health and finding the right care for people who have pelvic pain is the lack of access, and not everyone has access to doctors like you. So for people listening, what kind of suggestions or recommendations can you give to them if they're having trouble finding providers who can help them?
One of our biggest challenges is having patients who've had so many different types of treatments, but not in the right order. And so there's a lot of skipping over some of the more conservative things that we do, which always makes it a little bit harder to treat our patients, because they may be beyond what we can do for them. So for people who are earlier in their diagnosis, getting a proper physical therapy assessment before having surgery, before having nerve blocks, before all of that is actually good. I mean, assuming you're going to a good physical therapist who can understand the difference between an overactive muscle versus an underactive muscle. Quite often I have patients who come in and say, do I have pudendal neuralgia? Pudendal neuralgia, by definition, is just having pain in the distribution of the pudendal nerve. And since the pudendal nerve is inflamed or irritated, that's very different than having pudendal nerve entrapment. And when people are reading blogs and different sites on the internet, I have to remind them that it's actually not beneficial to Google, because you don't know what the care is. You don't know if you're getting the same care in the same order. And you may not end up in that situation because you may have access to doctors and to different treatments before those people. And you also have to understand the people who are doing well and have been treated are not sitting there on their internet writing stories about their recovery. Although we would love if they did, but there's not a lot of that out there. So trying to avoid all that negativity and trying to find people who can do more conservative treatments way before doing anything surgical is huge. A lot of people will fly in, so try to get to major cities for treatment. It's super important, because you really don't want to have surgeries or procedures that might set you back.
And I think that's a great point about trying to avoid the online forums and blogs. I was talking to another doctor a few weeks ago who essentially said something very similar, that the horror stories you read on these platforms are not a reflection of the population of people that are improving, which is actually a large population. So sometimes I think that can be detrimental to people.
Definitely.
And for everyone listening, if they want to contact you or come to your office, ask you any questions, where can they do so? You
can find our information on pelvicrehabilitation.com. Our website has all of my social media, including Instagram, Dr. Tayyaba Ahmed, AHMED. And I will be in the Long Island office, hopefully later this year. So we will have many more locations, so I'm excited.
Congratulations.
Thank you.
And thank you for talking about these conditions that many physicians aren't speaking much about, and providing hope to so many people who really need it. Thank you.
Thank you for all the work you're doing.
Yeah, my pleasure. If you can relate to this video, please leave a comment below and share it with anyone else who you think may benefit. Thank you.